Welcome to the Hearing Reviews webinar, Hearing Healthcare in the Era of COVID-19. I'm Carl Strum, editor of the Hearing Review magazine and its website at hearingreview.com. We have two special guests today. Joining us are Dr. Douglas Beck and Clifford Olson, and I will formally introduce them after a couple of housekeeping items. Today's plan is to answer the question about what is the current state of hearing healthcare in the wake of the coronavirus, and what will be the lasting effects of COVID-19 on the management of our patients and our businesses. Dr. Beck and Dr. Olson and I will talk about where we are right now and how we think the current recovery might play out, while addressing important factors, including what might happen if and when we see a resurgence in the pandemic and what to do about it. We'll cover several other topics like the PPP and AuD loans, and wrap it up with a discussion about possible long-term effects of the coronavirus, probably focusing most on teleaudiology and infection control and best practices. In between, we'll have a couple online polls for our audience and that were submitted by our sponsor. And following the discussion, time permitting, we'll answer some questions from the audience. Please feel free to submit those questions anytime via the questions box on your toolbar screen. Also, we had some advanced questions submitted on the webinar registration screen. So when we get to the Q&A segment, we'll try to address those as well. I'll be posting a resources document that will provide links to anything that we cite during the presentation, and that'll be available in the handout section next week, or just feel free to drop me a note too if you want to do that. Now a short message from our sponsor. We'd like to take a moment to thank our exclusive sponsor, Hamilton Captel. This kind of support is just one example of their commitment to the hearing healthcare industry. As you know, Hamilton Captel is a leading provider of caption telephones. What you may not know is that Hamilton Captel created the Hearing Healthcare Program just for hearing healthcare professionals. Through this unique program, it's never been easier to engage your patients and connect with them on what matters most in their lives. Learn more at hamiltoncaptel.com/HHC. Today's webinar is being recorded, and you'll receive an email tomorrow with a link to that recording. It will also be available to new registrants, and you can see it at GoToWebinar for the next 3 months. So thank you guys for joining me. I'll activate my webcam too here, and thanks for being here. How are you?
Thanks for having us, Carl. It's great.
Doing well, Carl. Thank you.
Good. We've got a ton to cover today, so I'll just start launching into it. But first, I'll introduce you to Dr. Douglas Beck, and I have worked together for more than 2 decades. Sorry about that, Doug. And I've come to appreciate his in-depth expertise in a variety of audiology disciplines, including as a researcher of cochlear implants and intraoperative cranial nerve monitoring at the House Ear Institute in Los Angeles. He was the director of audiology at St. Louis University. He co-owned a private practice, and he's now the vice president of academic sciences for Oticon. He's also served as the online editor-in-chief for the AAA website, audiologyonline.com and healthyhearing.com, and is also the senior editor of the clinical research for the Hearing Reviews Inside the Research column, which spotlights stellar research in our field. Dr. Clifford Olson is the founder of his private practice, Applied Hearing Solutions in the Phoenix area, as well as with his wife, Ashley, the creator of the Dr. Cliff AuD YouTube channel. Dr. Olson earned his doctoral degree from the University of Illinois, where he is also an adjunct professor or lecturer for the Department of Speech and Hearing Science. Dr. Cliff is an unwavering supporter of best practices in hearing care and an advocate for individuals with hearing loss, which inspired him to develop the Dr. Cliff Approved Provider Network. His Dr. Cliff videos are both extremely entertaining and informative, and I have to say that Cliff is probably the closest thing you can get to being an internet sensation if you're an audiologist who is tasked with talking about ear molds and audiograms. So welcome, gentlemen, and thank you for your participation today.
You're welcome.
Great, thank you.
We'll start right off and get into this, and maybe I'll start with Doug here. What have you been experiencing, Doug, relative to the coronavirus and your work, and how do you envision the potential recovery of the hearing healthcare market moving forward?
Okay, that's a big question. Now we've got what, 6 hours, right? So,
Right.
you know, what I've experienced is an overwhelming sense that we should have been more prepared as a profession and as licensed healthcare professionals. I was so proud of my company and many others that immediately when this was known to be a pandemic, you know, we pulled people off the road. And the most important thing was their safety, the safety of employees, our colleagues, and of course the patients, because when you think about it, the average age of a new patient in an audiology practice is about 67, right? If you go back to Market Track 9, they said it was 69, Market Track 10 said 66. So let's call it 67, 68. And those are the people who are most susceptible to developing COVID. And so it was so great to see our entire profession, our industry say, you know what, this is going to cause personal pain for many of us and our patients, but we have to keep the patients safe. So I experienced that firsthand, and I saw so many of my colleagues rushing to learn about viruses, about personal protective equipment, and you know, looking at webinars. I did one with Auxi Vankaitis from Oak Tree. It was absolutely stellar, talking about the difference in different type glove types, different mask types, different personal protection, but not just from the professional's viewpoint, but to take care of the patients and make sure that they were as safe as possible during their visits. And of course, you know, the emergence into telehealth, which 6 months ago was maybe 2 to 5% of all hearing care professionals even bothered with it. And now I don't know, Carl, you have the most recent survey, but I'm suspecting about 65 to 70% of all healthcare, hearing care professionals have jumped into it and you know, are exploring how to use it.
Right. Yeah, over half have used it, and we'll get into teleaudiology in a little bit, but yeah, it has been booming, and manufacturers have been you know, just cranking out whatever they can to help with you know, and assist with the patient contact and counseling. Cliff, what kind of things have you been seeing in private practice? And I know the Phoenix area there has had a resurgence, or Arizona's had a resurgence in COVID. What are your experiences with the recovery?
Well, I mean, recovery, I think, is going well. I mean, I think that, you know, there was a couple surveys that had been done, you know, back in, you know, the March, April timeframe discussing, you know, what the atmosphere was like right when this all started to hit. And the same thing happened in my clinic. I mean, even if we were keeping our doors open and saying that we were, you know, taking patients like normal, the vast majority of, you know, especially new patients were just canceling their appointments and not coming in anyway. So regardless whether or not we had enough PPE inside the clinic, there was just nobody coming in. And, you know, you can only do so much drop off, you know, repair and maintenance service that only takes you so far. Even though my clinic isn't necessarily a completely bundled clinic, there is revenue associated with that. But, you know, people were just apprehensive of coming in. Now, I would say that, you know, in May, April was really rough. May was starting to get a little bit better. And then June, it almost feels like we're kind of almost full recovery, at least in my clinic. But the problem is, like you said, is that we now have had kind of, at least in Arizona, and we thought that we were escaping the worst of it. Arizona has had a huge increase in positive tests, and you can debate all you want on the like, is that more testing? Is it just more infection? Whatever the case may be, it's really irrelevant, because at the end of the day, it depends on if consumers are actually willing to come into the clinic now that we have all the, you know, appropriate, you know, safety protocols in place from an infection control standpoint. So, you know, I'm optimistic. I think that, you know, to some degree, people are a little bit burnt out about stopping and going and living their normal lives. So I think that, consumers in general are more willing to come in. But we're still tasked with keeping them safe. And if we don't feel like we can do and practice care safely, I think we might revert back a little bit to what we saw kind of in May with, still seeing some new patients, but a lot of, people canceling their appointments.
Right. Yeah. Our third survey showed that, about in April, less than a third of the practices were open and seeing patients, and in May, about 3/4 were. By June, about maybe 5 to 10% were not open or physically seeing patients. So, I think the recovery has gone really quite strongly for independent practice. VA is another story, right? But that's kind of how I've seen it going from the industry standpoint. Doug, would you agree?
Yeah, I think that's fair, and I think you'll see the VA, open very, very cautiously and slowly, and appropriately so. And I think that even though the VA is a tremendous resource for all of us, it needs to be extraordinarily cautious, and I think they've taken that approach, and I think they're to be applauded for that. And I think once they feel it's safe, and I believe that'll be later in June. Or perhaps July, by the time they're all open, they'll have a good grip on how to keep patients safe, to see them in an efficacious manner, and to take care to make sure that everybody, that health is the #1 issue, that we are doing things properly, we're doing things that are in the patient's best interest, and we're addressing their hearing healthcare needs.
And Cliff, in your practice, I've had dentists send me things about how they're changing their protocol and some of that. Have you been doing that in your practice? I mean, what kinds of things that we can control, that we can do that will facilitate the recovery of a practice?
Yeah, just ridiculous amounts of sanitation is one thing that's happening. I mean, I guess, and it's kind of to our discredit, we probably should have been doing more. Right, and this is kind of just made light of, like, oh yeah, maybe we should be sanitizing these certain pieces of equipment, or the desks and the chairs and whatnot in between patients already, and this has just kind of brought it to the forefront. So that has become something that is a standard now inside of the clinic, and will probably honestly remain a standard for some amount of time. And then of course the good old call when you get here, because we're just going to bring you right in to our office. And and I've seen reports from other audiologists who say that it doesn't matter how much signage you put up, people are still going to walk in the front door. And so you just have to be able to handle that situation by being able to kind of go up and cutting them off and say, stop them at least in the entrance of the building, and have them go back out to their car and wait until they get there. So that has been something that's really big. And then also just limiting the need for people to have to come in. I mean, the United States Postal Service has been making more money off of my clinic because we're doing a lot more shipping, of repairs, batteries, supplies, demo device, like trial devices, in case their hearing aids go down for a period of time, and we need to send their devices directly from their house into the manufacturer, and then send it right back to the patient, and then they come drop off the hearing aids. And a lot of my patients come in from not necessarily in my immediate local area, so we have to have this ability to do a little bit longer distance care. And then of course, and I know we're going to talk about it a little bit later, this teleaudiology aspect of it. Fortunately, my clinic was set up really well with hearing aids that we've been fitting over the last year and a half that accommodate a lot of that. And we fortunately had a lot of people set up to be able to utilize that. So,
and if I can jump in on that, because one of the points that Cliff made early on just now is so important, that a lot of us were caught off guard, and that it's kind of shame on us, because when you think about respiratory disease, when you think about diseases, viruses, and bacteria that can be spread through casual conversation and through sneezes and coughs, you're looking at a huge list, right? Coronavirus, of course, SARS, MERS, influenza, tuberculosis, measles, leprosy, pneumonia. I mean, And it's just amazing that we got to 2020 without being more cautious. And, universal precautions from the CDC, the Centers for Disease Control, came out in the early 80s. I was at the House Ear Institute then, and it's when the AIDS epidemic first hit, right? And I was working in the operating rooms, and we used to physically double glove and double mask and all of these things because we didn't know, 40 years ago, how AIDS was spread. And for those of us who were doing intraoperative cranial nerve monitoring, of course, we're inserting needles into the patient to monitor different nerves. And needle sticks in operating rooms, not that unusual. It happens. And so, you do the best you can, and a double glove doesn't really protect you very much, because if you're going to get a direct needle stick, it's going to go right through that latex anyway. But that's all we had. So that's what we did. And my only point then is that people say this all the time. Is this the new normal? Is this? So I think things will calm down. I think once we get past the pandemic and once we get a vaccine, things will change. But I think we should always maintain a higher level of universal precaution than we have traditionally maintained, because in audiology clinics, hearing aid clinics, even ENT offices, we're right in the patient's face. We're talking to them. We're examining their ears. I think virtually all of us, sanitize, probe tip for tympanometry and for reflex testing and speculum and things like that, or we use disposable. I think as of now, all of that stuff should just go to disposable. There shouldn't even be a chance that it wasn't, cleansed properly. And I'll tell you, in the operating room, we changed about 30 years ago. We used to, when I first started, we used to reuse needles. They were sent to the autoclave and they were sterilized. That's not a guarantee that they're clean. That means they have been sterilized. They're anyway. So different discussion for a different day. But I totally agree with Cliff. We were caught off guard, and our level of universal precautions was just about zero. And I think that between where we are now and where we were, we should settle probably about 60%. And we have to think this through and be very careful, because it is life and death. It's not a trivial issue, and we have to do a better job.
Right. Well, turning back to the recovery, what other broader factors like recession and unemployment how are they going to figure into it? Do you see these as really affecting hearing aid dispensing, particularly in private practice?
I don't know if I do. And just coming up through grad school, I remember reading a lot of studies talking about the inelasticity of hearing aids in general. So they tend to weather recession pretty well. You can make all the arguments you want about hearing treatment being a necessity or not, but clearly consumers feel that being able to hear is something that's important enough to spend money on, even when there's a recession going on. And then you also have this disconnect between Wall Street and Main Street, right? So a lot of individuals who are making purchasing decisions on hearing treatment are typically past this point of where what's happening on Main Street actually affects their income significantly. And if the stock market's doing well and their investment in the retirement income's doing well, I think that they feel more comfortable coming in to receive treatment. Now, my perspective might be a little different than another clinic's perspective. My clinic definitely caters to this, you come in, you get what you pay for, so people are willing to spend, more on the higher end of that income level. So we don't necessarily see a whole lot of individuals who come in because they're looking for just some kind of an affordable option. And that's just kind of the position that my clinic has. And so, I don't think that we kind of I don't get price conscious customers who come in or price conscious patients who come into my clinic. But I can foresee that a lot of clinics out there who work in more maybe rural areas or who are working with individuals who are more, still in the workforce, I think that it would be something that would potentially impact them.
And so the issue on elasticity, that was written and addressed by Amin Amlani, and it's an absolutely brilliant series of papers. I think he wrote 2 on them, maybe 3. And I agree with everything Cliff just said. The thing about hearing aid patients, now that we're in the world of PSAPs and pretty soon OTC, I don't think that OTC is much of a threat. When you go back to the 800 people who were surveyed by Healthy Hearing, which I think was in 2017, they said, so if you could buy it really expensive from a practice like, a premium practice, or you could buy over the counter, what would you prefer? And the overwhelming response, like 85–90% of the people said, oh, I definitely want an over the counter product. But then the next question was, how much would you be willing to spend? And they said, well, price is no object, maybe up to $100. So the point is, they were never our patients to begin with. And this is a very, very important point, that the people who are shopping OTC in general are not, they're not looking for Dr. Cliff. They're not looking for best practices. They're not looking for outcomes measures. They're not looking for ethical treatment. They're looking for a product. They're looking for a widget. And this is the thing about professional practice, is that we are above and beyond that. And the patients who come to see us are, frankly, somewhat disabled by their hearing or their listening disorder. And so they're looking for a product that will solve that problem. Now, if the patient is just looking for the world to be a little bit louder, maybe an OTC would help if they have normal thresholds, or maybe a mild loss. But I think it's a very, very different market. And I think that, as Cliff said, I don't think we're going to see a huge impact in the near future. I think that the onus is a little bit on us to make sure that we are providing those services, because products, even though there are extraordinary products in our profession, the product is in my opinion, not the biggest part. The biggest part is your expertise, your knowledge, you're adhering to best practice, you're adhering to your scope of practice. You're treating the patient with due respect and dignity, and doing the very best you know how to do, and not taking shortcuts because you can. And I think that when we have this North Star compass, when we're really, really, really out there for the very best we can do for the patient, no competition. We're awesome.
And yeah, and getting great outcomes and providing the value. So let's move. What happens if and when we see a resurgence? And now, Cliff, you're dealing with it, but any other things that a practice can do to prepare for what might be an inevitability?
Yeah, I mean, I think that I think we have to really have a serious discussion about us being able to provide some kind of teleaudiology option, remote diagnostic testing, something to use as a stopgap, maybe not like replacing best practices, but something that we can have some kind of positive impact on an individual as hearing loss without them having to come inside of our clinic. And if we're not thinking about it right now, if we think that the worst is over, and it might be, but if we're thinking that way, then we're thinking about it the wrong way. We really need to start thinking about, what if this goes on in perpetuity? What if in 5 years from now, we're still having this discussion of like, is it safe to go in and see a healthcare provider, period? And if we're not, thinking of ways to do better contactless delivery of different services and products, then I think that we leave ourselves susceptible to this happening to us again. And I think it would be a travesty if that's the case. Now, I know that there's different regulations and laws in place, and I'm not going to make the argument that we should just, ignore, the licensing boards and the state guidelines and rules, really, that really prevent us from doing a lot of this stuff. But we need to start having those discussions, because until we do, things are going to stay the same, and we're going to continue to struggle if this thing really drags out.
Right. I want to touch really briefly on PPP and the AuD loans. It appears from our survey that about 70% of people applied for, and about 65% of private practice and retail outlets ended up getting the PPP loan. It looks like it was a really important thing for about 3/4 of dispensing professionals, at least from our survey. Would you guys agree with that?
Yeah, I think it was brilliant. I was surprised they were able to enact it as quickly as they did. And I know that there were a lot of impediments, and it didn't roll out as smoothly as it perhaps might have. But the fact that that the federal government was able to do something extraordinarily beneficial for private practices, that was great. Now, but as you know, there's more to that than the HCP side of it. Apparently, an awful lot of that money got misdirected, which is terrifically unfortunate. and shameful, and I don't want to get into the politics of that. But as far as we're concerned, the ability of hearing healthcare practices to keep the lights on and to pay employees so they would have healthcare and be able to pay their bills. I'm very grateful for the PPP. I think it was a great move at the right time, and I think that if it has to happen again, they'll know how to do it better next time. But I think it's very important, and I'm grateful that it happened.
Sorry, Carl. I should preface my response to this as I'm grateful for the PPP. I was fortunately able to receive a PPP loan. On the other hand, it was very crazy in the implementation of it, to the point where you had no clue what was going on, and there was so much stress involved in this idea. Are we going to get it? Did we fill everything out the right way? Who's in control of it? Am I really going to get this forgiven? Am I not going to get there's just so many different variables that I still don't know what's going to happen with it. I don't know that if for the 2 months that I've been paying my staff and not making a whole lot of income with the clinic, I don't know if that's truly going to be forgiven or not. I like to think that it will be, but at the end of the day, I mean, it could end up being a really expensive time to keep the employees paid. And in the defense of the Paycheck Protection Program, and I actually said this in one of my vlogs, it's not a payroll protection program. It's not meant for the practice owners. It's meant for the employees, so individuals who they're trying to prevent people from getting fired, right? They're trying to keep people employed so they have incomes and whatnot. So I get the premise of it. I'm still a little bit up in the air of whether or not it'll come back to bite me in the end.
Good comments. How do you think the pandemic might, let's just touch, we don't have a ton of time to go into it, but how do you think the pandemic will impact some of the industry changing trends that we've been seeing in the first place? Whether it's OTC or big box or some of the blended care models or managed care. Let's start with OTC. Do you think that the pandemic has affected OTC devices and that whole debate?
Well, to a large extent, it already has, right? Because the federal government, the FDA, was supposed to give us guidelines that were supposed to drop in the fall of 2019, which still haven't seen the light of day. And OTC was supposed to become a law August 2020. So I think that's extraordinarily unlikely because of the pandemic. Obviously, the folks at the FDA have other things to do, So, and I don't say that in a negative or sarcastic way. I mean, there are things much more in the OTC law right now. So I think they're going to get around to it. My personal opinion, probably 2021, we'll see it happen. But the OTC, again, it's a different patient, it's a different consumer, it's a different end user. They're not exactly the same people who've been walking into the clinics for the first, 75 years of audiology. So I think for the emerging market of OTC, when it happens, because right now there is no OTC, that it's not a legal term, you're not allowed to advertise or to promote that you do OTC. So I think for the people who are going to seek that, they're probably, there's a good chance they would buy it at Walmart.com or another big box retailer online anyway, because if it's truly OTC. Now there's an alternative model, which, for instance, Washington University, I just had a brilliant conversation with Mike Valente, and what they're, and Carl, I believe you're publishing that in Hearing Review early in July. That'll be right online, and I think in print in September. And they had a brilliant model for this, and I want to share this with the clinicians. If I can I spend about 90 seconds describing it? Sure. So what he did at WashU, and they sell roughly, they dispense roughly about 75 hearing aids a month, and Mike was saying about 7% of those people are looking for options and are interested in options where they can get 2 hearing aids out the door with real ear, with a test box appraisal of the hearing aid for less than $1,000. And I think that probably 7% is about right. I think that the vast majority of patients, when they demo hearing aids, when they see how much noise reduction you can actually get, and when you can see how much easier it is to listen and to hear, I think they'll be more impressed with the upper levels of technology if they're given a chance to demo it and to listen to it and to wear it in the real world, which they generally are. They have a 30-day trial. But Mike, Mike Valente, Dr. Valente was talking about, with OTC, it's not likely that they're going to start advertising, $399 hearing aid, guaranteed not to rust, bust, collect dust within 30 days, money fully back. That's probably not going to happen in most clinics. But the model of having an entry-level product that you can get 2 of them for $1,000 with appropriate, audiometric guidance, I think is a really good idea. And I'd like to see us, promoting that rather than, spend $399 and get a product that you don't know anything about or how to use it. I mean, so you get the idea. That's just, in essence, and if I said that wrong, Washington University and Mike Valente, I apologize. I'll just refer you to the interview that'll come out the first week of July. But I like that model a lot better, and I think it's more pragmatic for the people who are looking for the $300, $400, $500 hearing aids. Not to say those $300, $400, $500 hearing aids won't get a lot better in the next few years. They probably will. But at this point, we don't know what they are. We don't know what the rules are. We don't know what the specs are, and we don't know who the appropriate candidates are. So, so there are some things. So I don't think the pandemic is going to impact OTC right now, because there is no OTC. But I think in lesser priced hearing aids, there are some good options, and I think that that we have to talk about those and really talk about, because it's so expensive to run an audiology practice, and Cliff knows this better than any of us. He's putting up a brand new building in Phoenix right now, and on average it costs about $250 an hour to keep the lights on in an audiology practice. And I wonder, when people are selling PSAPs or OTCs at $99, $199, I just don't see how that's good for us. But I can envision that there is a very good opportunity, the one that Washington University and Dr. Mike Valente speak about in this article.
Right. And how about, big box, or, how do you think that the epidemic or the pandemic has affected that? Cliff, do you have any thoughts about that?
Yeah, big box, there's been a lot of discussion going around, because I think big box felt really compelled to kind of close down the hearing centers that they had, and left a lot of disgruntled individuals with their hearing devices that were needing care during this time, and literally were just not able to get it. And there's no like, here's what you can do instead, here's an accommodation, nothing. It was just, oh, we're closed and sorry, I think that they have been having discussions, and they have been starting to reopen, so credit to them for that. But this aspect of being able to provide some kind of care or some kind of accommodation, private practices are very nimble compared to really large entities, and so private practices are able to kind of modify how they provide care delivery much better than a really large institution. And on top of big box, I would also add on to the direct to consumer hearing device market that's online. I think that from the perspective of that, if those companies are not absolutely capitalizing and killing it during this time, when the from the in-clinic perspective has been decimated to some degree, then it really makes you question about the long-term efficacy of that delivery model of hearing devices. I think it will still serve a portion of individuals with hearing loss, but is it going to completely overtake the private practice model? I think the answer to that will end up probably being no.
Right.
Yeah, and there's evidence to support what Cliff has said. And when you talk about DTC, it's not one product. There's obviously range. But there was a recent paper that came out of the UK by my buddy Kevin Monroe and Pierce Dawes and Harvey Dillon and others. And they talked about 28 different direct-to-consumer products. And they looked at them over, I think it was 150 or so patients. And they found, this is just a quote from that paper, on every parameter measured, there were devices that performed worse than the standard NHS device. Most of the devices, the DTC, were rated lower in terms of aesthetic design than the NHS device, and provided gain frequency responses in MPO that were markedly different from those prescribed by the audiograms, based on NAL, NL2. So I'm not saying that it's not going to emerge, it's not going to become brilliant, but at this point, yeah, I take Cliff's points very seriously, and I think he's exactly right. And that paper, so anybody who wants to look that up, that was British Academy of Audiology in the fall of 19. I was honored to be there and presenting, and I saw that paper, and I thought, wow, I didn't know that.
Right. I'm going to take a little break here, and we're going to launch a poll from the sponsor. This first poll, I would request that just dispensing professionals. We've got a ton of people online and a lot of industry people, but if I could just confine this poll to dispensing professionals, and then everybody else can go on the other polls. But this poll is for dispensers. And the question is, what office management software are you currently using? Select one of the following, and those are your options. If you would please indicate it and then hit your submit button, and we'll see what we get. Give it a couple minutes here. All right. And it looks like I will close the poll and share the results here. And that's what we got. It looks like 49% either don't use any of the above or don't use an OMS system. 22% with Cycle and Blueprint, and the rest following afterwards. Thank you very much. I'm going to go right to our second poll, and the second poll is, what are some topics you'd like some more information on? And select one or more of the following. Go ahead and you can select, and this is for everybody. Select 2 or 3 or however many you want. And then submit. We're getting lots of responses here. And looks like most people have voted. It's the majority. I'll close the poll and share the results here. And that's what we got. New technology and emerging trends in telehealth are leading the way here, and that doesn't really surprise me that much. Social isolation and hearing loss follows, along with marketing and helping veterans with hearing loss. So great, thank you so much for your help on that poll, and we will we'll return to our discussion. Let's turn, speaking of teleaudiology, then let's turn a little bit more toward that. How important has teleaudiology been for the field in the pandemic, and what do you see as it being incorporated in the future both now and in the future? Is this going to be kind of ingrained in our practices?
Yeah, I mean, I think teleaudiology is, I think it's something we missed the boat on initially, and you know, ever since remote care became available, I knew that to some degree, because we've been talking about, you know, online delivery models of hearing devices and whatever, whether from a in the clinic perspective or more likely a competition perspective. And you know, from a convenience standpoint, you know, in my clinic anyway, and I've mentioned this already, people travel quite some distance to see me in my clinic sometimes, and it's not necessarily convenient for me to have all of their fitting and follow-up sequence done inside of my office. And with, you know, this remote care side of things, where we can do follow-up reprogramming and things of that nature, we can accommodate a lot of these in-office visits remotely. And I'll be the first one to say that I think that there are a significant amount of limitations in terms of being able to provide best practice care completely remotely, but I see no reason why you can't incorporate aspects of it into a delivery model of hearing devices, or even an ongoing care perspective with devices. And I think that this has kind of been the shock to the system that we needed. And I've already given a couple presentations. I'm going to be giving another presentation here in the short future about how to implement remote care and deliver devices in that fashion. And, I think that the only thing really limiting us at this time are the legalities around it, and maybe some technological, things that we still need to have available if we're going to provide best practice care and do it in a remote fashion. So I think that, from what I've seen in my clinic anyway, over the course of April, we did a ton of remote sessions with patients. And if it wasn't for anything else other than to check in with them and possibly make some different adjustments in their devices, at least giving them the peace of mind that we had the ability to do something like that. And then, of course, using that to reinforce the importance of the in-clinic care, because anything that I can't do remotely, you kind of make it obvious to the patient that, well, for these things, we still need to have you back in the clinic. So in their mind, they realize that you can't replace everything that we're doing, at least not at this moment, with a remote delivery model of remote care.
And it's interesting in the survey, before the survey, the general kind of consensus of the industry people that I talked to were that about 25% had downloaded software, fitting software and the like, but only about 5% used it. And now the survey is showing that about half have used it for patient contact and fine tuning, but also in survey number 3, fewer used it for new patient first fits. But that might be a reflection of in May people getting back to opening up their practices and being able to have face-to-face types of interactions. But it was also kind of concerning that that the number of people saying that it wasn't applicable for their clients went up, and also about 40% said it was important for patient contact and counseling, but only 17% said it was important for revenue generation. So I think we still have a long, a fair way to go for people to feel real comfortable with teleaudiology systems and dealing, really maximizing the efficiency of their practice. And I think you're out in front, Cliff, on that.
Yeah, and
I would say, and sorry, Doug, I know it's your turn to respond. I would just like to say, and I'm not going to comment to every specific thing that you said in terms of those survey results, but I disagree strongly with a lot of perspectives of people who did not find that remote care to be valuable and not to be revenue generating. When we look at this aspect of the reason you have value, provide perceived value to consumers. And if you portray something as not having value, they're not going to perceive it as valuable. So I could talk all day about how I disagree with people's perception of how remote care just isn't very effective. I can't make money doing it. So I'll leave it at that. Maybe it's time another discussion we can have for that.
I'd love to have that discussion.
But all the points Cliff just made is right, because most of us are using a bundled model. So when we sold the hearing aids, we collected the revenue for the next 2 or 3 years. And then when you get on telehealth, yeah, there's not any revenue left because you sold it as a bundled model. And that also opens up the discussion about itemization. And if you go back, I think it was the PCAST or the NASM, so the President's Council and Advisors for Science and Technology in 2015, or NASM, National Academy of Science and Engineering and Medicine in 2016. They had their 12 points, right? One of them was get rid of the waiver. One of them was that we should have OTC products, and those they worked on right away. But there were 2 or 3 other points that they pointed out. One was that you should be itemizing. Now, I don't know how people feel about that because everybody's practice is their own practice and they get to do it the way they want. I have no issue with that. But the federal guidelines said that it would be smarter to do 2 things. Number 1, to itemize. And number 2, to have more CPT codes available for hearing care professionals so they can actually bill for services, not just diagnostics. So right now we're in this situation that almost has nothing to do with telehealth, because for you to bill a CPT code to Medicare, Medicaid, or many private insurances, your state has to allow you, first of all, to provide telehealth via licensure or via an emergency order, because right now we're not provided for that. Unless your state allows it. Number 2 is Medicare only allows us to do diagnostic services if they have first been referred, appropriately by a physician. So that's a roadblock. And then, payers only pay telehealth anyway for what they would have done face-to-face. So you have to put telehealth in the proper perspective, which is that you weren't getting paid for all those follow-up visits anyway, because if it was bundled, they were included. So this is just another way to do it. But I do think the future for telehealth is brilliant. I think that if I were still in private practice, I would try really earnestly to make sure that, you know, I'm delivering my products. And very soon after that, by the time the patient has decided to purchase it, I think probably most of those visits at that point could switch over to telehealth, to a quick touch base. How are you doing? Do you need any fine tuning? What have your observations been? What are the instruments doing that you like? What are they not? You know, what are they not doing that you would like them to do? And some of those fine tuning things I could do online instantly, but that would save me lots of hours of time in the clinic, which is much more valuable than if I take a 1 hour block of the day and I have 4 or 5 patients at 10 and 15 minutes each in telehealth, and I have a patient care coordinator coordinating that. So as soon as I hang up with one, I can go into the other. That could be an extraordinarily efficient way to practice. And I do think that we have to leave that door open, because it allows us access, and it allows the patients to access us, which is probably more important if and when, you know, the situation maintains or gets worse. So I think telehealth has a brilliant future, but it's not necessarily revenue generating at this moment in time, but that's not because it doesn't work. That's because of laws, and that's because of state licensure, and that's because of lots of other impediments that we have to address. And then telehealth will probably become tremendous and at you know, revenue generation. But right now, it's not set up for that.
I absolutely agree. And, you know, I think telehealth is absolutely critical for our industry to increase the efficiencies and to address the number of people that we should be addressing with hearing loss worldwide, for that matter. So I agree with everything you guys said about that. I want to talk a little bit, you know, since I have two of the most fierce advocates for best practices, I definitely want to talk a little bit about best practices, and I thought it'd be appropriate to show this slide with Mike Valente, since he's been at it for about 45 years, and I think he's been at Washington University for 35 years. And Mike did a kind of spearheaded a lot of the best practices things, along with a lot of other people. I know there's a lot of great advocates for best practices listening in on this too, having looked at the attendance list. But I'll give you guys a chance to why do we need to pay attention to best practices and understand them from our professional perspective and adhere to them.
Yeah, I mean, I would say that best practices are the things that we do that provide value to the patient. I mean, research proven that these are the things that get better, you know, performance for patients. And why wouldn't we be doing those things, especially in a time when every one of us feels potentially like we're at risk of being infiltrated by outside, disruptive models. And if we're not doing best practices, what value do you actually hold in this process? I mean, so you can help me maybe put a hearing aid on and in my ear and you can hit the auto program button. Like, is that what, gives you value? Or maybe that you're a nice guy or gal to talk to inside of the clinic. And I want to be politically correct here, a nice guy or lady to talk to inside of the clinic. I find it ridiculous that we would, to some degree, be resisting best practices in normal times. However, at this present moment that we are in, do I feel like it is a good idea to potentially forego offering comprehensive best practices because you literally cannot do it in a time of crisis like we're in right now? And I would say the answer to that is probably yes. I would say that any hearing care is better than no hearing care when the possibility of providing best practices isn't there. And I would say that, and I would agree with you, I feel like I'm a pretty outspoken advocate for the use of best practices and no excuses. There's no reason not to provide it. But in this particular scenario, I mean, I'm a relatively reasonable, logical individual, and I could say at this point that if you cannot do something, you have to figure out what you can do to fill in. And I've mentioned this before, as a stopgap to be able to provide some care now. And then once things start to clear up, you go back and you correct the improper fitting that you did by not following best practices to accommodate.
Right. That's all great points. I'm going to switch to our last poll here, and from our sponsor, and launch the poll. And this is from our sponsor. I will remind you. What are the top 2 resources, publications, brands you go to for hearing healthcare industry news? And then the choices below. Please submit, and we'll see what we get. We're still getting responses here. I will close the results and share the results, and 82% for the hearing review, followed by the hearing journal, and 62%. Hearing tracker probably isn't fair. Abrams hearing tracker is more of a consumer type of thing. So and Hearing Health Matters delves into the consumer end too. So thank you very much for participating in the poll, and I'll hide the results now. And so let's switch over to, we've got a few minutes left for questions, and I think it's a good idea to go to what we had submitted, what was submitted before. Should hearing care practices be investing in marketing right now, and or should they be saving their money? What are your recommendations for marketing practice right now, and what should be your what would be your key marketing messages?
Okay, well, you know what happens when you don't market? Nothing. So marketing is just critically important, right? You have to get your message out. And I think that the message you want to get out is about you as a person, you as a professional, you as an individual, and talk about, you know, improvements in quality of life and things like that. I don't think this is a time to stop marketing. If you stop marketing, you kind of disappear. And so that's the brief answer, because I know you've got like 85 questions. So that's my, Cliff, what do you think about that?
I don't think anyone should ever stop marketing ever. I mean, if not, and to be quite honest, I think marketing encompasses different things. I think that right now maybe is a better time to do what we call branding, and not trying to convince someone maybe to come into your clinic, but you're trying to build up your value in the eyes of people who would potentially come to your clinic at some point. Branding should never stop. If you need to put a pause because you literally can't afford to do, you know, extensive marketing to actually drive people into your clinic, there's no reason why you shouldn't be, you know, spreading top of mind awareness about you and what your what you offer in terms of value to potential patients in the future.
Right. Another question: can you bill for remote services in a fashion that justifies offering it?
Well, that's going to depend. You know, if it's a private pay patient, you have a lot more latitude. If it's a Medicare patient, if it's you know, a commercial insurance patient, you have to abide by the state laws and the federal laws. And so as we said a little bit earlier today, and obviously that question came in over the last few days, but you know, there was telehealth at this moment is more about communicating with the patient and being able to make, you know, adjustments and to address their needs. And as Cliff said, you know, that there are going to be some mistakes made when you rely on telehealth to be as efficient as a face-to-face visit. So as you know, I don't get to make the laws, and you know, I'm not a judge, but it seems to me that in a time of a pandemic, of a true medical emergency that the country is going through, 120,000 people have died in the last 4 months because of coronavirus. You do what you can to help them out, and I think that that's that's a solid way to go. But legally, you got to do it. You know, you got to pay attention to the laws. There's no excuse. You were illegal or you weren't, and you know, we each have to make those decisions. If it's a patient that you're familiar with and you know, you have a complete audio on them, that's a very different thing than dealing with a new patient online.
Right.
I charge regularly for teleaudiology sessions, remote care sessions, unless I'm mandated by some kind of contractual agreement, you know, with whether it's a third party or whether it's, you know, insurance or whatnot. But other than that, I mean, people are willing to pay for it. Guess what? If you provided them with the perception that it has value, they'll pay for it. If you treat it as like something like, oh, well, it's not really that good, but we can do it anyway, and you know, I feel bad charging you for it. Well, yeah, of course you're not going to be able to charge for it at that point.
The third question, and then we'll wrap it up here. Should the professional bodies develop guidelines for teleaudiology offerings, while adhering to best practices?
Well, my thought is yes, but I don't want to see it rushed, because this is all going to change. You know, had we had guidelines 6 months ago, they'd probably be to a large extent out of date because of a pandemic. So I think that, you know, cool heads have to prevail, and I think we have to give it time for AAA and IHS and ADA and ASHA and whoever else to really think this through, appoint, you know, subject matter experts, have a group meeting, much like we do for best practices, much like we do for ethics, that, you know, you need people, not just opinions, because we all have opinions, but really learned, deep opinions that are maybe scholarly and academic and clinical, work together to develop these guidelines. You know, if we do it off the cuff, we're probably going to make a lot of mistakes. Right.
Good point. All right, I think we're going to we'll wrap it up. I'd like to thank our sponsor, Hamilton Captel. They are a terrific group of people to work with and have a true dedication to our field, and I greatly appreciate their support. And of course, I'd like to thank our two distinguished guests, Dr. Douglas Beck of Oticon and Dr. Cliff Olson of Applied Hearing Solutions. Thanks, Doug and Cliff. Great information and always a pleasure. And an additional thank you to Cliff's wife and partner, Ashley Olson, HR Associate Editor, Stephanie Kim, and MedCore IT Wizard, Eli Patterson, for their help on the webinar. And finally, a big thanks to all of you for attending. If you have any questions or comments, we'd love to hear about future webinar suggestions. Please give me an email at kstrum@medcore.com. And thank you again for your participation, and be safe and kind. Thanks, everybody.
Thanks, Carl.
Thank you, Carl.